Welcome back to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
And on each episode, we chat about the most recent developments in sports medicine with experts from around the country. Hey there, fellow surgeons. It's Dr. Ashley Bassett.
And Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. You know, in our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care. In this episode, we're going to continue our discussion with Dr. Yoni Rosenblatt and focus on the rehab of different stabilization surgeries, including arthroscopic Bankart repair, Bankart with the addition of the remplissage procedure, and Latarjet reconstruction. We then wrap up the discussion on return to play and an important conversation on the psychological aspects of recovery.
Our conversation picks back up with an article from the March 2020 issue of Sports Health titled, A Comparison of Physical Therapy Protocols Between Open Latarjet Coracoid Transfer and Arthroscopic Bankart Repair. Dr. Nik Verma and his team at Rush reviewed 31 PT protocols and found a high degree of variability with regards to exercises and motion goal recommendations. Despite the variability, many milestones and start dates occurred earlier in Latarjet protocols when compared to Bankart-specific protocols, which may contribute to earlier return to play metrics identified in the literature for Latarjet compared to Bankart repair.
Next, we review an article titled Functional Rehabilitation and Return to Play After Arthroscopic Surgical Stabilization for Anterior Shoulder Instability. This was published in the December 2021 issue of Sports Health. In this case series, Dr. Brian Busconi and colleagues at UMass evaluated 62 athletes who underwent arthroscopic Bankart repair and were subsequently cleared to return to sports using both functional and psychological testing. The average time to pass psychological testing was 5 months, while the average time to pass functional testing was 6 months. The redislocation rate of 2 years was 6.5%, lower than what is currently published for this population.
We finish up today with an article from the October 2022 issue of AJSM titled Relationship of SI-RSI Scores to Return to Sports After Surgical Stabilization of Glenohumeral Instability. Dr. Rossi and colleagues in Argentina reported that patients who returned to sports and those who returned to their pre-injury sports level were significantly more psychologically ready than those who did not return. In fact, for every 10-point increase in the SI-RSI score, the odds of returning to sports increased by 2.9 times. Furthermore, those that did not achieve their pre-injury sports level showed poorer psychological readiness to return to play and SI-RSI score results. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allograft starts with JRF Ortho. To learn more, visit jrfortho.org.
Okay, so you start to say, basically you're still seeing the conservative ones. You're still like, I don't know. It's hard. Like I would say for the surgeon sort of side of things, like the training we get is so limited in like rehab and like that whole, so, that sort of idea of like, oh, just steal somebody else's protocol. It's like people are like on the way out of fellowship and then it's like you're about to graduate and you're like, shoot, I got to steal these protocols because I don't know. No one's ever talked to me about like rehab before. Right. So I think it's a little scary because you just focus all like for a decade, you're so focused on like surgery and like how to fix the problem and how to diagnose the problem and stuff. And then nobody ever talks to you about the after. So I'm not surprised that, you still get a lot of variability and then you do something a little different than what they have on the paper and then they freak out because they're like, oh God, I lost control. So there just needs to be more education and it's just not happening.
Well, that's why I love what you guys were talking about prior, which is like that you have your Rolodex of PTs you trust.
Yeah.
And I've seen this, by the way, where newer surgeons will come into the area and they will come in and interview me to kind of see if I fit whatever it is they're looking for. Yeah. And I think that's awesome. I love that. And by the way, that builds rapport so that, I can't tell you how many patients come to me first and say, hey, I got this tear. Who do I go to?
Yeah. Mm-hmm. Or like, it's just that comfort of sort of saying like, hey, I'm worried about somebody. You know what I mean? Or, whatever, like this person stopped showing up or they're just like mentally. So when I was still a physical therapist, there's this gentleman, Dr. Maninder Coker. Ashley knows him. We trained under him in Boston. He's more like adolescent pediatric sports medicine. And, there'd be a couple times where I'd be like rehabbing his patients, that adolescent ACL, and I'd be really worried about them because mentally you could just see, and like, I just didn't know, like, what would you like me to do about this or whatever. And he was always so available. And it was just, I knew if I called his office, I would get a call back from somebody, if not him. And, it was just, you knew that like that person would be taken care of and you sort of felt like there was like this continuum and that you were a team. And so I think those relationships are really important. And it just like, you want to be able to like trust that person that they're going to do right by the patient and like be respectful of the protocol, but then also say to you, hey, I think we can start this a little earlier and, give you a little feedback and sort of say, because I think when I do this, it's totally fine. And, we should all be doing that back and forth.
Yeah, no question. That where it's really valuable is I see NFL athletes from across the country, right? Yeah. And so it is unbelievable. I will give him a shout out, Dr. Myers at Vincera, because the amount of time that guy has spent with me on the phone, concerned about his patients, is incredible. Yeah. Juxtaposed to, I'll see some bigger names. Right. Dude, they have no idea how their athlete is doing because they have never asked me. They've never seen a note, and they wouldn't even understand my note. And so it really, you find both. So I love that you guys are reaching out and being in touch. But Ashley, I cut you off.
Oh, no, I was just going to add something that kind of what we were talking about before about we leave fellowship and we just grab whatever PT protocol we can. I would almost argue I try to do the opposite. Like when I got out, you're not as busy when you first start. I try to do a literature search for every, like I do with everything. I did a literature search for every single surgery I did to try to come up with the evidence-based PT protocol, right? I wanted to use that. And I just felt like I was drowning because every single paper said something different. There was this PT protocol from this PT protocol from that. They're like, don't you dare move that shoulder. How are you not moving that shoulder? Don't start strengthening. Why aren't you starting strengthening? And I just remember being so overwhelmed because, as you said, Catherine, we're not taught that. So I'm trying to use literature, and the literature is all over the place. Yep. And so I feel like we owe it as an orthopedic community first. There needs to be more of an emphasis on PT literature. There's not. Doing a search for this episode, like AJSM, JSES, like they don't have a lot of articles about this side. It's all about surgery, implants, number one. Number two, we need to get consistent, come up with some standardized protocols for standard surgeries to give our PT community so it isn't all over the place and they're not having to check the protocol every time they make a decision with a patient for fear they're going to get retribution, right? So I think that's something I really hope comes out in the future, because it'll not only, I think, make us better care providers, but also make it easier for our like PT colleagues as well too.
Yeah, I think it's, it's a tough space at times to research unbelievably. There's so much gray in our world because not everything is standardized. I mean, you could do a supine external rotation with 3 pounds, and that's not enough information to tell me how that exercise was performed. There are just so many variables, especially in the shoulder. So it's tough to research, let alone who is supervising that therapy, what was their training, what is the environment? There are just so many factors. It's similar to the nutritional world where there's so many external factors. This is why you can't find one answer to lose weight or to gain muscle, or there's some themes, but it's very hard with all the things that we can't control versus your world, which is the patient is asleep. You're taking pictures inside the shoulder. You are measuring things, right, to a millimeter. There's a lot more that's controlled. Yeah, exactly. So I think maybe that's why. And by the way, that's part of what I love about what I do. But it's also part of why there are a lot of crappy ass PTs, because it takes a long time to build a Rolodex in your brain of this works, this doesn't. There are millions of variables.
Yeah,
absolutely.
Yeah, agree. And so we're talking about that specifically about Bankart. As far as like when do you start? And then we did want to talk a little bit about Pat Denard and Albert Lynn's paper where it talks about remplissage. So, as far as like the Bankart, we know that there's some complications, there's some challenges. Sometimes people need to do, more either bony work or they have to add the remplissage. Are you seeing an increased number of remplissage in the postoperative patients coming into your clinic?
Yes, short answer. It's crazy. Baltimore has a reputation of being a forward-thinking medical community, and that's because of Hopkins, really. It is, I would say, less impressive in the sports world. And so we have a lot of doctors that are very slow to come around, and we have some doctors that it's a slam dunk that they're going to be doing the latest and greatest and can tell you why and can tell you how they're doing the procedures and why they're doing what they're doing. So I'm definitely seeing more. It's not as much as I would have hoped. I go to Massis and I'm learning about all these surgical techniques, and I'm looking around the room. I'm like, why the hell is this shoulder god in Baltimore not doing this? Well, it's a matter of like how up on the literature and how thoughtful you are with what you're doing.
Now, with the remplissage, are you seeing any difference in terms of recovery? I don't know about you, Catherine. I don't limit them in any way. It's the exact same protocol for a Bankart versus Bankart with remplissage, but we hear in the literature of some loss of rotation. And also, Larry Galata was pointing out when we were having our webinar about some posterior cuff pain. Are you seeing that in remplissage patients?
I'm really not. I haven't. Patients can come in, and it would be a challenge for me to pick out who had the remplissage and who didn't. And that's coming from a guy who, when an ACL walks in, I can pick who did their surgery by the way they're walking. So I'm noticing this stuff, and I could not tell you other than the fact that they seem to be more stable, which is the idea.
That is the idea.
And the posterior cuff pain, I think, makes sense that, like, I would say I talk to people about it as a possibility, but I can't say I've actually seen it as like a consistent theme that they're having this like, pain that's a little bit more than a traditional traditional like sort of shoulder surgery. Like, so I can't say I see anything there either. Ashley, do you?
No, I completely agree. And then with the loss of rotation, because we also talked about that when we were talking about doing that webinar, that I think it's based on where you put the anchors. So like if you put it right there at that margin and like really tighten up that capsule and really shut down that joint space, like they're going to lose rotation. But like you just put it dead center in the hill sacks. And especially I think nowadays that we're using it more as like an added check rein. So we're not using these giant hill sacks. It's just maybe a high risk patient with, a hill sack that maybe is non-engaging, but they've got 7% bone loss and they're a contact athlete and they're male. So you just want to back it up. If you put it dead center in the small hill sacks, I don't think we're going to see a rotational loss. So I haven't seen that. And I don't think I would do a remplissage in a giant hill sacks with bone loss. I think I'd probably talk about doing something more like a open bony stabilization procedure.
Now, if it's a pitcher, is that going to change your calculus with remplissage?
Yeah, I think you have to think about those things. I think there's a lot coming into play with like, what's their age? What are they trying to do? I think that is like definitely a discussion you have to have with the patient. Like the risk is like, okay, like, are we going to be like changing your rotation such that it's really going to impact your performance or maybe not allow you to get back, And I think if I'm, the doc with that patient, I'm having that discussion of like that this could mean that you need an additional surgery later if we skip the remplissage, but that's probably a risk worth taking to allow you to try to get back and have that mobility. Because if we take away that mobility, like I don't have a good way that I can really get it back.
Yeah.
I don't know.
Absolutely. I also think we have to think about the pathology we're treating, right? So pitchers, I feel like have more of like a chronic attenuation of like their anterior inferior capsulolabral complex. I would anticipate they'd probably not have significant bony deficit, maybe not a huge hill sacks lesion. And of course, if they have a dislocation snowboarding and they're a pitcher, a different story. But I think most of the instabilities that I'm seeing in a pitching athlete tend to be more like chronic attenuation with a non-displaced labrum tear. And in that case, I don't think I would do a remplissage. But I think the tricky part would come, as Catherine was alluding to, if it's like snowboarder dislocations, a true like one that you would consider remplissage and they're a pitcher, I think you have that conversation and you just let them know the risks and benefits and let them make the decision.
Yeah, that makes sense.
Yeah. Awesome. So I think we beat remplissage to death. So let's talk about Latarjet versus Bankart. So our next paper by Nik Verma and his team at Rush looked at PT protocols, kind of what we were talking about, right? They looked at about 30-something PT protocols, found they all said something different. They tried to compare Bankart to Latarjet, and they found that Latarjet patients were able to hit their milestones earlier. They were able to do more things early in their PT, which they thought perhaps led to an earlier return to sports and some of those early return to sport metrics that they were seeing. So is this consistent with what you're seeing? Do you feel like the Latarjet patients progress quicker through their recovery, or is it surgeon dependent?
No, I definitely think it's just a more stable repair and a more stable surgery on the flip side. It's just less apprehension. It's less shifting inside of joint. They just feel more comfortable. So yeah, they do progress. I will say Latarjet has come a long way, I'd say, in the last 10 years. I used to see a Latarjet and man, they're hiking like crazy. They're missing 20 degrees of abduction, and it was a mess. And over the last 10 years, it has gotten worlds better to the point where the only difference I really see is that the patient just feels more stable.
Yeah. One of the guys I trained under, Tom Hackett in Vail, like it always sticks in my head. He always used the term bomb-proof. Like, just be like, your shoulder's just bomb-proof, go. Like, just,
it's not going anywhere.
It's going to take, like, some terrible, terrible thing. Because, he would see, like, the Navy SEAL population or, these guys who are, like, out. Like, you cannot have your shoulder redislocating where you are. You know what I mean? Like if you are out in the environment, like I need this to be bomb-proof. And, and I think that's exactly what you're saying. They just feel like so much more stable, much more quickly. Yeah. But obviously, that surgery also has, it has different complications that we have to think about. And, it has a little bit more risk. It has a bigger incision, for the most part. Some people are doing an arthroscopic, but I would say it's sort of like a kind of quasi-arthroscopic. They start off arthroscopic and then still open a bit. But any complications or things that, Yoni, you're seeing in your clinic that like are different, or what's on the negative sort of side?
I think the negative is horizontal adduction. Okay. I mean, it doesn't show up that much. It might. I had a quarterback who went through a Latarjet, and he had some issues like as he's putting his thumb in his opposite pocket, like coming across on follow through. That it bothered him a little bit. It wasn't anything he could work through. He's a great case of the guy's going to get blown up in the pocket. It better be stable, right? Yeah. So a little bit different than maxing out your layback with a pitcher that you're going to be more worried about like every single degree. Quarterback is far less so, but I think it's that. I think it's just that horizontal adduction. Sometimes they get a little bit what I call pinchy, for lack of a better term, overhead. So I'll see my CrossFitters have some issues with their snatch work, and we'll just like change their grip a little bit. But again, I think that's the trade-off for that increased stability.
Yeah, makes sense.
Awesome. So now we want to talk about one of our favorite topics, which is return to play.
ACLs. Oh, okay.
Yeah, I know. Let's just give up the shoulder. Let's talk about ACL. So no, we want to talk about safe return to play after surgery. So this is obviously really important. We talk about it a lot with ACL, but it's really important with shoulder stabilization. So recent literature is suggesting that the use of a return to play test to determine clearance may lower the rate of re-injury. So our next paper by Brian Visconti and team at UMass demonstrated that the use of a combined functional assessment and psychological screen was associated with significantly lower rate of redislocation. So are you performing functional assessments for patients after shoulder stabilization surgery to determine if they are prepared to return to play?
Hell yes.
Yeah.
I mean, I think, and by the way, I think it helps the psychological side. I will say I don't run a psychological battery on them to figure out their readiness to return, although I know there's value in that. What I try to do is treat the entire athlete every single time they come in. Part of that is their mental health and their confidence. And if they are crushing their return to sport testing, they're obviously going to feel far more confident. You know, we use the single arm push-up test because it is so jarring to the joint that if you can handle that, you're going to be in good stead. But also, use of simple technology has really come a long way. So we'll use a crane scale or what's called a tin deck, which is just a really small force monitor, and it'll give you rate of force development. It'll give you your max force, and it'll freeze it. It makes it really easy. It comes with a phone app, and it's super easy to hook up in your clinic. It costs like $150. Every clinic should be doing that, and we will test them in very standardized position. We'll test them max external rotation effort at neutral. We'll test them at 90-90, and then we'll do internal rotation as well. Then we have good literature. Then we have good objective data so that we can come back and say, hey, you're this percent. Let's get you to that percent. Are you better? Are you worse? Versus, hey, how do you feel? So I love that. On the higher end of things, we've been using force plates. Yeah. And so we'll put our patients in a supine position at an IYT and measure their max efforts. And we'll do that. That's awesome for stability because that is a very vulnerable position of the patient overhead, especially with that abduction, because the joint is totally exposed. So how much force can you create in that position? How confident are you there? That's one of my favorite tests when I'm diagnosing labral tears is how confident do you feel there? How much force can you do there? Okay, let me put my entire hand on your anterior capsule and hold that humerus inside a glenoid where it should be. Oh, you're so much better. Well, because I'm doing the job of your labrum. So go to Ashley and let her fix your labrum so we can get back at this stuff, right? But those are some of the return to sport stuff that we're doing. And then we also do, every once in a while, I'll dust off the closed kinetic chain upper extremity where we're timing taps and things like that. I like that because it pulls in your core. You have to be able to really stabilize appropriately. We do a lot of core work that becomes a very heavy home exercise focus for our patients. And that's the way we really gauge their return to sport. And then you want to make sure when you're going out and interviewing these PTs, do they have a place and a know-how to, if you're working with a thrower, to get out and throw, to video your throwing sessions, the understanding to periodize your return to throw programming, things of that nature, or put it in the cross. Do they know what a good snatch is? Do they know what a clean should look like? How is the shoulder moving appropriately? The patient has to prove to themselves that they can do it. They can't do that if the therapist doesn't know what it should look like. So just thinking those things through, I want to always be in a facility that an athlete can do everything they need to do on the field in my office.
So I'm going to ask you like sort of an in the weeds question. When you're doing the force plates and you're testing them supine for the YTIs, Are you like, where's the pressure? Is it on like the back of their hand, or are you doing it on the forearm? Like, how do you stay consistent with that?
Forearm, great question. I want to limit that as much as possible. We're going to measure the angle of their shoulder so that that's uniform. We're going to put them in a hook lying position when they're doing that, so that they are able to stabilize appropriately, so that we can try to remove as much gray as possible.
Yeah, it's tricky. Like, so we do a lot of exercise testing in my clinic. Our lower extremity stuff, I feel, is like really dialed. The upper extremity stuff, where like we actually had this meeting, like it was like as soon as we got back from the holidays, where like we just carved out like 3 hours to like play with some physical therapists and my staff of like my 2 athletic trainers, and just sort of say like, how do we want to do our shoulder testing? How do we want to, because it's not as like concrete as like the ACL sort of testing. We don't have as much data around it. I was really excited by this study because it tried to really put some like, like we're talking about, there's not enough evidence out there, or there's not enough standardization, and they're really trying to do that. So I thought they did a great job in this paper, and also incorporating the psychological. But I think that's a good tip. Like, we basically have been doing, because the way our force plates like suggest is you should be doing these tests prone. And I'm like, but that doesn't make sense to, you know what I mean? Do it prone. Like what? I don't know.
Well, it's really easy to cheat those, right? So just like when we're doing Tindex testing for QI, for quad indexing, like we belt our patient down to their plot. The only thing that can move is their knee, right? Yeah. So you want to try to isolate that as much as possible. And I think the shoulder is super vulnerable in that supine position because of the anterior translation.
Yeah. Mm-hmm. I think those are really, really good tips, and I'm going to share them with my team.
Hell yeah. Well, honestly, I love that you're talking to them about that, because I've lost my mind at Massis about this, but it's crazy to me when a patient goes back to their doctor, and then the patient comes back to me like, yep, doctor cleared me for return to sport. Yes. I'm like, what?
Yeah, it's the return to sport testing really has opened my eyes into that. We really think patients are ready before they're actually ready. Like when I was in fellowship, we were doing a study on return to play testing after ACL, and we compared it to historical controls, and we looked at when the surgeon thought they were ready and then sent them for the testing. And it was like 85% of the time the surgeons would have cleared someone that was like grossly not ready to undergo. And these are like, I did my fellowship at Rothman. These are Rothman surgeons that are well trained, that work with professional athletes, and they're like, you look good. And then they go out there and they're not good. Their balance is all off. Their limb symmetry is terrible, and you don't realize that until you test them. And then you get the patient buy-in. When I turn around, I show them the test and they have fail written down. I've all like 5 of the 7 columns for a shoulder. I just had one. She thought she was absolutely ready to get back to volleyball. I mean, she's not contact, but still. And I'm like, look at how bad you did. And she was like, oh, okay, I'll keep going to PT then. Thank you. It allows them to get buy-in as well too. So it protects us, it protects them. It's hugely important. We should do it for every joint, personally, I think.
I had Jamie, who's like at my front office. She was like, she messaged me and she's like, so-and-so called. They want to be cleared for skiing. And I was like, over the phone? Like, she's like, yes. I was like, no.
Oh, and they're 3 months out from their ACL. They feel great. That's awesome.
And they're on top of the mountain, so they need to hear back.
Well, appreciate this. It was a bare ACL. So what you'll see with the bare ACLs, they feel so good. They're just like, I'm ready. And you're like, no, you're not. Like, you're still like, you feel good. Your pain's down relative, I think, to traditional ACLs. But you still have to do all the work. Like,
yeah.
Exactly.
It's a lot of work.
Yeah, it was funny. I was like, over the phone? Like, anyway. No, I think all those things are super helpful. I think the psychological stuff like plays into, Yoni, as you indicated, like how they're moving. If like they're not moving well, obviously psychologically that's gonna, indicate, like it's almost like two-way street. Like you can't have one without the other.
Yeah, I think it's super important. I would say, like, since you're talking about like tricks of the trade, when you're talking Bankart or Latarjet, once their motion is back, the game is stability, right? And motor control, especially overhead or in the vulnerable positions. So it's super important that I'd say you guys relate to your therapist or therapists that are listening that you are actually challenging that stability at whatever end range they have. And that can come from a wide array of things, whether it be rhythmic stabilization. You'll see like some of the higher level Strength coaches are awesome at this, especially in the baseball world, of putting them at end ranges and doing manual resistances are super important, but also being able to handle one load, so heavy Turkish get-ups and the ability to handle that, but also unstable Turkish get-ups. Like, how do they do when things aren't going perfectly and things aren't perfectly in line? Can they react and adjust? It's just important that happens. And it bleeds into the previous conversation, which is there's no way a doctor in your setup can look at that. Not because you don't know how. It's just they're sitting on a table and, it's just not conducive.
Because it's the same thing, even like, and there's the other caveat, which like we do have a ton of equipment to test people out. But like the caveat I always give them is like, you're not fatigued right now. Like I'm just sort of like testing you in this little, like just to give me a little data. This data goes to your physical therapist. They're also going to test a bunch of different things. But then say when it comes to like, say a lacrosse player who has shoulder instability, and like, how are you at the end of the game when you've been nailed like a million times,
Right.
And it's just like, are you still like able to absorb that force and, not feel like, oh my gosh, like, that fatigue factor is like, no matter how well we try and test people, like, and that's where you're talking about, like when you're talking about the thrower, like you have to do that gradation to get them back because they have to sort of build up that endurance as well as all like the sport-specific skills and the strength and the fine motor, So I think no matter what we do, there's always little pieces that we're not, capturing.
For sure.
So the last thing we want to talk about is you talked a little bit about you don't do psychological screens, but obviously you're with them every day. So you're not every day, but 3 days a week, assessing them and seeing kind of how they feel. So something I found interesting about the paper we just talked about is that patients pass the psychological screen before they pass the physical screen. So they pass the psychological screen at about 5 months and then the physical screen around 6 months. So they felt prepared to go back in before they were physically ready, which I feel like usually they're linked, kind of like you said. If they're not feeling good about their shoulder, they're not performing well, they're not going to be psychologically ready. But this found something a little different. So our final paper looked at the shoulder instability RSI score to predict ability to return to their pre-injury level of sport participation, and found that the higher RSI score predicted return to pre-injury levels. So what are your thoughts on this? Do you feel like fear of re-injury holds patients back from getting back in, even if physically they're recovering well? And if so, how do you think we should address this?
So yes, I do see that. So I would agree with that. I'm not surprised by that outcome. I'm also not surprised that a lot of patients think they're better than they are. I just think that's the nature of the beast, especially in a high-level athlete. They're always going to think that they're the best. And they use that to their advantage. The way to incorporate this into clinical practice is to give your patient the hardest thing you think that they can accomplish appropriately with good form and good technique and things like that. And that's how you build their confidence. I mean, when you have an athlete go through these return to tests that I mentioned, but also as a piece of return to test, what's your med ball velocity like? What's your throwing velocity like? How many reps have you done? Have you been on a mound? Have you thrown to your PT? Things like that. If they've already done that stuff in the clinic, it's going to match what they can do, right? That's the way I feel. I always used to say, like, I don't treat above the neck. But it's really not true. Like, we really do. And with every single exercise and every single session, that's why I harp on the import of not wasting a session. Every single session, you need to be challenging that athlete. Now, sometimes that's just with a cane exercise, but sometimes that's with a max velocity med ball toss. So as long as you're challenging appropriately, giving them a chance to succeed and not beating them down by giving them things that are too hard, those should become lockstep, I think is the phrase. They should happen together.
Yeah,
that makes sense.
Yeah, Yoni, I think that is a really good point, to therapists or, and really to doctors too. Like anytime you have a visit, like you should get as much value out of that visit as you can. Because all of these things are so multifactorial, whether it's like the physical or the mental, and it's, even just, sort of listening or challenging or, whatever, all these things are going to come out. So I think, just that alone is a really good piece of advice, just that you got to try and get that value out of everything. And like, sometimes that doctor's visit is like, oh, I'm just here to like take out their stitches. You know what I mean? But it's, there's probably some other things that we can be doing,
Absolutely. I think that also just we're increasingly realizing how much people really struggle with injury, not only with the surgery, but with injury. Catherine, I mean, you started a whole program surrounding this, to try to help people through the mental
knows
side.
Emily.
Oh,
Yoni knows Emily.
Oh, so yeah.
She's the best.
And it's really important. I mean, up until a few years ago, I didn't know who to send someone to if they were struggling. And a lot of my not a lot, but a few of my ACL patients were really struggling not being with their team and really were becoming withdrawn. They didn't want to go to school. It's really hard. And we're kind of at a loss of how to deal with that. But there's this renewed focus on sports psychologists, sports psychiatrists, and getting people the help they need. That's a really important part. Your mind isn't in it. Like, it doesn't matter how much physical you do. I agree with you, Yoni. I think they're linked. But if someone's held back mentally, I don't know if they can fully recover until we address that as well.
Yeah, it's true. Like, I think, Emily, like, I think for, both Ashley and I, we do probably draw a specific type of patient that sort of looks at us and thinks they're going to listen to me, Yes. You know what I mean? Like someone who maybe already knows I'm feeling anxious or I'm feeling like, a little worried about undergoing this surgery. And so it's a big part of my population where I just have people who are really high achievers. They're super type A, so that when they have these sort of challenges, it's sort of like they've lost some control. They struggle with that for a period of time. And they're like, okay, but my expectation, like, I had someone recently, it's like, who came in from the other side of the state who drove 5 hours just because she's sort of like, I'm not doing as well as other people in my community. And it's just sort of like, wasn't even one of my operative patients, but it was sort of like, I need to know why am I not as good? And there was nothing structurally wrong. It just was like that, it's a spectrum and it's a hard sort of recovery, and people recover at all different types of speeds and stuff. But I think understanding like what Emily Perrin does, she does a lot of great work and just trying to, either normalize a lot of those feelings, but also just giving people like the tools to sort of reduce that anxiety and understand like how that they can, work through some of those challenges.
Yeah. Yeah. I think it's really important. I see it now. I'm working with an NFL player who blew his Achilles, had it repaired. He cannot go a day without being compared to Aaron Rodgers.
Oh yeah.
Right. And so it's, and by the way, two totally different surgeries. I mean, different techniques. We don't have to get into it, but the expectations are totally different for those surgeries, but it doesn't matter. He walks into his locker room and they're like, I saw Rodgers throwing. Yeah, exactly. Yeah. So it can be tough.
It's such a bad precedent to start.
I know.
Don't get me started. I get so mad. As someone who likes to stick to protocols and follow literature, because I have Achilles patients too that are like, thankfully, like they're reasonable people, but they're not like, but they're like, I mean, he was like walking, like weight bearing without a boot 2 weeks after surgery. Like, why am I in this? And I'm like, oh God, here we go. It's just, it's hard to correct that kind of expectation. So that has to be challenging.
No question.
Yeah, for sure.
Yeah. Awesome. Well, this was an awesome conversation. Yeah. I learned a ton, and now I know who to reach out to when I have PT protocol questions instead of racking my head against the wall looking at PubMed. So
I'm happy to help. This was great. Thank you guys so much for having me on. I learned a ton, and I love the way you guys go about it. I love your approach and how thoughtful you guys are. It's just awesome to see docs operating at this level. It's really awesome.
Well, you obviously do great work, and I like. Your clinic has an excellent reputation. You have an excellent reputation. Like I, first came across you, through lacrosse and the PLL, and every athlete that you work with, is always just has like a million great things to say, and you help them get to where they need. So you're at the head of your game. So thank you for all you do, and we really appreciate you sharing all your tips and tricks.
Thank you guys. Appreciate you both.
Yeah. Thank you. Bye. Right. Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We love your feedback.